Hi, this is Brooke Hensley,
And I'm Judy Saint-Bourg.
and today we're going to talk about the ultrasound diagnosis of appendicitis. And the first step is your probe selection. You can either use the high frequency linear probe or the low frequency curvilinear probe. And we'll show you examples of images using both. And for patient positioning, you want to have them lying supine on the bed, and on the left you can see various anatomic positions of appendices. Normally they're generally in the right lower quadrant, but it varies from person to person. So I think the easiest thing is to ask the patient to point on their abdomen with one finger where it hurts the most and just place the probe there. And for the technique, first you place the probe at maximal tenderness and you do a graded compression technique just to get the bowel gas out of the way and maximize your images.
All right, so let's review here some of the anatomy we'll encounter when you put the probe at the right lower quadrant. So first here is the pelvic outline, pelvic rim, and then the yellow line up top defines your peritoneal line. Here in red, you see the psoas muscles, and then you'll have internally to the psoas muscles your iliac vessels. And the area of interest is usually just up top the psoas and the iliac vessels. So if the patient has pain in the right lower quadrant and you can't easily identify your appendix right away, you can just go around about that area to find your appendix. And so, as we just talked about, should be in that area here.
So some of the diagnostic criteria you'll be looking for once you kind of hone in on the area that you want to focus your interest are, first, you want to see a non-compressible blind-ended tubular structure. It lacks peristalsis, and it's at least 6 millimeters in diameter. And here, this image on the right is an example of acute appendicitis that meets all these criteria. But of note, the black outer wall is not actually fluid, but it's actually part of the outer wall, so you want to make sure you include that in your measurement for the 6 millimeter measurement. And here are just a couple of examples, and just like any image that you ultrasound, you want to visualize it in two orthogonal planes. And here, first, right here, you see it in longitudinal view. And then when you turn it 90 degrees, you see something called a target sign, which is just the transverse view of the appendix, where it is a nice little ring. And this is a great example of the transverse view target sign. And on the left, you can see as you're fanning through this tubular structure, the target sign actually disappears, so you know it's actually a blind-ended structure. And also on the right, when you're measuring that target sign, again, you're including that black outer wall. And this is just an example of a laparoscopic image on the right of an appendix where it's close to the peritoneal wall. And as the appendix becomes more and more inflamed, you have more of a localization of the pain where the appendix is actually touching the peritoneum. And here on the left, you see an ultrasound image where you see the appendix coming up and irritating the peritoneal wall. And just to kind of drive home the point is that's a really great place to start, is have the patient point where they're having the most pain with one finger. And this is just another example. We're going to go through and show you a bunch of different examples of how different appendicitis can look on ultrasound. But again, you have to stick to those diagnostic criteria that we talked about before. And again, another example where you can actually see the examiner on the ultrasound pressing down on the abdomen right there. But there's no peristalsis and it's non-compressible.
So some secondary supportive criteria that can help us diagnose appendicitis if it wasn't clear with the basic criteria we gave you earlier on is the presence of an appendicolith, which is going to be very white and bright, so hyperechoic, and is going to cast a shadow, usually if it's big enough. Periappendiceal fluid that can be present also, and just free fluid in your normal fast view. These don't have to be present, but if they are present, it just supports the diagnosis. So here is another example of a big appendicolith here that's casting a shadow, as you can tell here, and that would be a very big appendicitis, and a little bit of free fluid around the appendix here. Another example here of appendicolith in the lumen of your appendix, which is still this nice tubular structure that has no peristalsis. Here another example of periappendiceal fluid. So if you do see that, it definitely means there's inflammation in that region. Here's yet another example of a nice appendicolith with some shadowing, which is always nice to be able to see.
And another important thing to consider is that you can sometimes encounter a normal appendix during your ultrasound. It's actually difficult to see, so it's great if you can see it. And normal appendices, just like the one pictured on the right, can be very prominent and very long. And sometimes you can see it on the ultrasound as you see in the still image on the left. That's why it's very important to stick to those criteria. And a normal appendix that's not inflamed is not going to be it is going to be compressible, and you will still see peristalsis there. So just because you see this blind-ended pouch doesn't necessarily mean that you made the diagnosis. So just keep that in mind.
Okay, so let's go over some of the limitations of this appendix ultrasound. So as with any other ultrasound studies, patient habitus, excessive bowel gas, and operator experience can hinder the view of the appendix we're trying to image. As well, severe pain and guarding can make it hard for us to image the region of interest, and so giving the patient analgesia prior to our exam can facilitate this. And also, it is known that ultrasound isn't as sensitive as CT scan to diagnose ruptured appendicitis, and so just to keep in mind that sometimes it can be hard to see the appendix when it is ruptured. There are some criteria in the literature to help us diagnose ruptured appendicitis, but we won't go over them in detail today. Some pitfalls as well to the diagnosis of appendicitis is remember to measure the diameter from outer wall to outer wall, and so to include the black outer wall, which is edematous wall of the appendix. Also, important to know that you have to visualize the entire length of the appendix to make sure not to miss tip appendicitis, which can sometimes happen early on. And also always remember, this is not a rule-out test. It's a rule-in test.
All right, just to go over some take-home points. Number one, first step is to choose either the linear or the curvilinear probe, and patient body habitus may determine which one you choose for that one. You want to do graded compression at the point of maximal tenderness. The diagnostic criteria are 1, non-compressible blind-ended pouch, 2, aperistalsis, 3, greater than 6 millimeters in diameter. And don't forget that further imaging may be warranted if the ultrasound is equivocal, because overall it's not as sensitive as CT, but it will vary from patient to patient, so just keep that in mind. Thank you very much for listening, and don't forget to visit our website.
Thank you.
Thank you.